Welcome, everyone, to today's webinar, How to Meet Your Patient's Price Transparency Expectations. I'm Aaliyah Pavla with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. You can also download the slides for today's presentation in the resources section on your dashboard. With that, and at this time, I am pleased to introduce today's speaker, Howard Bright. Howard is the Vice President of Patient Engagement at RevSpring. Howard has over 28 years of experience in healthcare and information technology, covering healthcare revenue cycle, as well as technology, product development, and operations. As Vice President of Patient Engagement at RevSpring, he is tasked with developing and launching new products in the pre-service patient access space that leverage RevSpring's established capabilities in patient statements and online payments. Howard also oversees RevSpring's healthcare appointment reminder product and business unit, as well as RevSpring's analytics and data science business unit. Howard has done podcasts for Becker's Healthcare and has been published in Becker's Hospital Review and the Electronic Health Reporter. It is now my pleasure to turn the floor over to Howard to begin today's presentation.
Thanks, Aaliyah, and welcome everybody. I really appreciate everybody taking time out of your very busy days, I know, to spend an hour with us to talk about meeting patient expectations, especially around price transparency and collections. So we will spend this hour talking about a lot of different things, covering a wide variety of topics, but mainly around engaging your patients and using some of these regulations that are out there as opportunities to build better relationships with patients instead of looking at them as like huge tasks that you have to that you just have to check the box on. I will start by just talking about the patient, how patients have changed over, the almost 30 years now that I've worked in healthcare IT and revenue cycle. What is happening now over the last, 3-5 years or so, patients, of course, are now a lot more interested in understanding what their costs are. They're more plugged into and in tune with medical costs. A lot of this, of course, is driven by high deductible health plans. They are covering an increasing portion of the healthcare bill. So a long time ago, they had deductibles that were $500 or so. Now they've got deductibles that are $5,000, $8,000. So they are basically the new payer to some degree. Simultaneous to that, with what has progressed with mobile phones and the internet, and what has been going on in retail around payments, the patients are also expecting from the healthcare world what they are experiencing over on the retail side. This has caused a shift over on the provider side. I think if, as a provider, if you're not keeping up with the times and trying to keep up with what patient expectations are, I think you'll see bad debt start to go up and collections start to decrease. So I do think there's some opportunities here actually to swing this around, make it a tragic to magic thing, and take advantage of what patients want and actually use that to your advantage going forward. The patient behavior and patient expectations, some of the things specifically, Selfserve is a big part of it. today, more and more, patients are consumers. They want to do things on their own, use self-serve options. Like, why can't I just do this on the phone? Why do I have to call? They want to do things on their phones. It's very mobile. The patient population is, as it ages, you're bringing in more mobile and digital natives. Definitely looking to just understand more information about their bill and why they owe a certain amount, especially if they're on the hook for it. And they're just looking for a seamless, seamless experience. So basically what I have done to this point is probably told you something that you already know. Everything here at this point is not new in healthcare, so it's been the trend of the last 5 years or so, and I really want to talk about how we can swing this around and use this to our advantage in the provider market. One approach here is to really build a unified patient engagement experience, breaking down these silos of the clinical experiences over here as far as engaging patients, payments and billing post-service is over here with engaging patients, and then the patient access, patient intake world is a totally different silo. A lot of these pieces can and should work together. Patients don't really look at it as, oh, I need to talk to patient accounting, this is back office stuff, and oh, I need to talk to patient access because I have a visit coming up, and then, the clinical team is totally separate. It's possible to just roll that all together in a single patient engagement experience. And one of the easier ways to do that, one of the first places to do that is at least combine the payments and the billing and the back-end patient accounting pieces with the pre-service patient access and patient intake tasks so that you can really engage the patient from end to end, at least on the revenue cycle axis. One big piece in healthcare that we always have to worry about is regulation. There's always something around the corner that is going to get passed from the government that we always have to keep our eyes on and figure out how we're going to stay in compliance. Again, it is possible to take these regulations and shift gears on them and see how that could actually be an advantage, something that you can leverage to increase your patient engagement experience rather than make it worse. Two of the biggest ones that are coming down the pike that really affect patients is the price transparency ruling, which went into effect this past January 1st, where you have to expose your negotiated rates so that consumers can shop for prices. That went into effect January 1, and then what's coming up this January 1 of 22, of course, is the No Surprises Act, which has a lot of requirements around out-of-network billing and surprise billing. But it does have, on No Surprises, a lot of opportunity to engage patients because there's some patient notification pieces of No Surprises. Just a quick recap on No Surprises. On the No Surprises Act, this is something that was enacted by Congress last December. It was wrapped up in the giant Appropriations Act. That in the big news story that came out of that was the $900 million in COVID relief funding, and that really, led the news stories when that thing came out. But what was in there was this No Surprises Act, and it was slipped in there as a consumer protection ruling, mainly to protect patients from surprise medical bills, primarily in the emergency and urgent care scenarios. What has happened recently this year, so in the summer, we finally got the first ruling where HHS has taken what the legislation from Congress and actually turning it into an actual rule that has to be complied with. So back in July, they released an interim final rule. They took comments. That comment period ended back in early September. But this actually was the first time that things got out, to the provider and payer community to understand specifically what it was that has to be what has to be complied with. It mainly focused on just the flat out, what was already passed by Congress, prohibiting balance billing and making sure that cost sharing amounts for out of network were in network in most cases. And then how those in-network amounts had to be calculated since these are out-of-network providers. But there were two big pieces in here that I do want to address in more detail a little later is about patient notification. So these actually turn into patient engagement opportunities where you have a patient coming in. There's some pretty strict requirements, onerous requirements about notifying patients or engaging your patients. And so I think if you have a great patient engagement strategy in place already, these patient notifications can just roll right in there with it. As far as these notifications, main thing is to notify patients around this surprise billing. So just right off the bat, surprise billing, which is basically where out-of-network providers charge the patient for the difference between what they bill the insurance, the patient's insurance, and what the insurance will pay. That's just flat out banned in emergency situations. And it also limits the cost sharing. So we're talking co-payments, deductibles, co-insurances, and out-of-pocket maxes, limiting them to what would be the same as if they were in-network. But one big piece of this that came out of this is the disclosure. So there are some scenarios where it's possible to bill out-of-network rates if you're an in-network facility for out-of-network providers, but there is a whole list of disclosures and notifications that have to be put in place to do this. So just right off the bat, providers have to put this one-page disclosure, make it publicly available, put it on their website, put it as signs in the facility, but also this last third bullet, as you see here, they have to actually distribute this to individuals, email, snail mail, or just hand it over to them. So this is a patient engagement situation where a patient is about to get a service. There is a lot of they're out of network, so they're about to be charged out of network fees. So this is around billing and what they're going to have to owe. And now, in above and beyond everything else that you want to interact with the patient with, you have this extra disclosure that you now have to hand to them. In addition to that, sorry, HHS also did publish an example of what this disclosure has to look like. So you could see it better if you download the slide deck, but this is just sort of an example. The 2-pager's got a lot of information in there with their consumer protections, and this has to be, again, handed to the patient or sent to them electronically. In addition to a generic disclosure, which is just a general statement that says that they have rights for their out-of-network because they're getting charged out-of-network rates, they also have to provide the patient with a plain language notice that has to be specific to their particular service. And they have to get a consent, similar to like an ABN. They have to get a consent from the patient ahead of time to say that it's okay or that they're aware that they're going to be billed out-of-network rates, even though they're at an in-network facility. What's interesting about this is a lot of the details here is that it has to be given to them 72 hours prior to the actual service. So from a patient engagement standpoint, this is something that's new. So if you're dealing with a patient coming in and they're in network and they have an out-of-network physician that's going to be providing any of these services, you have to be able to build this patient engagement piece. You got to be able to build this electronic notice. and build it into your process so that 3 days prior to the visit, it makes its way out to them. Also of interest is that for anything scheduled within 3 days, then they have to get this notice out to them on the same day they scheduled the service. And if it's same day, you have to make them wait 3 hours to give them enough time to be able to view this and sign this information. It's also worth noting that there has to be an estimate on it, a good faith estimate of what their costs would be. This sort of ties into price transparency and the ability to calculate what a patient's responsibility will be. So this dovetails into any processes that you may have around the estimation tools. One other thing about this notification, it has to be provided voluntarily, and it's the interesting thing for me on this is that it has to be specific to the individual and the circumstances. So this isn't just a form letter that you can hand them like that disclosure is. This has to be has to list specifically the services they're getting, how much it's going to cost them, and then they actually have to sign it electronically or actually physically sign it. Without that, you cannot bill them out-of-network rates. Similar to the disclosure, HHS has issued an example of what, basically a model notification of what this would look like. It's actually a 4-page document. Probably it might be hard to see on the screen. Again, if you download the PowerPoint, you'll be able to see this form, with a lot more detail. But the big takeaway here is that it's issued as a form that's labeled as a protection form. Again, this is a consumer protection move from the federal government, and that being very clear to the patient that they may be paying more at this facility than they could be somewhere else, and that by signing this document and paying out-of-network, they are waiving rights. So it is worded in a way that makes it very clear to the patient that they may not be paying the most, they may be paying more than they need to be paying. Also of interest on here on page, at least in the example, is a estimate. So there's actually a detail that you have to list the date of service and the billing codes and description and how much it's going to cost, and that has to be part of what needs to be signed. So this is a huge, this is a situation where you have a federal regulation coming in that is forcing you to have a patient engagement strategy to be able to engage these patients. And I think, it's an opportunity to be able to roll this into whatever engagement strategy you have now and use it as an informational tool and a patient satisfaction tool. So real quick before we move on, just a quick poll question to get a feel for the audience. Do you and your organization now, do you have a method in place now that you can send tailored notifications to patients prior to their visit, specifically just to address this surprise billing regulation? Just curious to see where everybody is. Just a couple minutes to let some answers come in. So the big answer I'm seeing is the no, we have to implement one. So that's interesting. It's interesting in that this regulation is putting a new burden on providers, but hopefully this could help you in bringing in a solution that can help expand your overall patient engagement strategy, because if you're able to do this, there's a lot of other ways that you could reach out to patients prior prior to service, in addition to, telling them they have out-of-network charges. Other big regulation is price transparency. This one's been out for a while. Again, went into effect on January 1. Just as a recap, this is requiring every hospital every year to make public a list of their standard charges for all items and services that they provide. The big key here is that there's actually 5 values that you have to, that providers, hospitals have to provide. The one that's probably the biggest news in here is number 3 on this slide here, which is payer-specific negotiated charges. So providers were already required to publish their charge masters. So number 1 was already in place. Number 2 was never controversial. A lot of providers publish that that they'll take a cash discount, self-pay discount. But number 3 was the one that really put an additional burden on it, and this is the one that this ruling was trying to address, which is that consumers want to know what it's going to cost them for their specific insurance, as opposed to what just the gross charges are. The minimum requirement was just to publish 2 files. So one machine-readable file that had everything in it, all 5 of those data elements, and then a second file that humans could read, a human readable file that contained just a minimum of 300 shoppable services. And so as long as those 2 files were created and placed out there, then you were in compliance, then the hospital's in compliance. One thing, worth noting is that that 300 shoppable services has to include, again, the negotiated rates for every in-network plan. So as you can imagine, it's a pretty large file because you got 300. It's basically 300 shoppable services times, for every one of those, it has to be times every single plan. So if you have 30 in-network plans, you're talking, 6,000 entries in this giant file. One thing we have found is that most hospitals are not complying with this rule. So there's been a lot of news stories out there about the fact that hospitals have either ignored the ruling or half implemented it. So now that we're already in October and ending out 21, it's interesting now. There's a lot of services that are going out and looking to see who's compliant and who's not, and it hasn't really been as adopted as much as I think the federal government would have expected. Could do another quick poll. Again, trying to get a feel for the audience. In your organization, how do you feel you've complied with the price transparency ruling? And keep in mind that it only applies to hospitals. So if you're not a hospital, then you didn't have to actually publish your results. So we can take just a second here to see the feedback and how you felt you did. And I hope everybody on the call is aware of this, that this was actually due last January 1st. Okay. Looks like it's kind of spread out pretty evenly, but it is heartening to see that over 50% are compliant, or more if you just take out the ones that it didn't apply to. So that's pretty promising. One thing that's interesting here is tracking what's going to happen with price transparency. I think there was a lot of hospitals who thought this would blow over or it wouldn't be enforced, but there has been a lot of energy towards trying to put some teeth into this regulation. So if you look out in the news, you're seeing a couple of consumer advocacy groups have formed around pointing out the hospitals and the large health systems who aren't publishing prices. Big push here is that consumers need to know this pricing, and it's their right, and now it's the law of the land. Also, there's been letters from Congress to HHS asking them to put more teeth into the penalties. So since it's $300 a day non-compliance fee, there are some hospitals that have said, hey, we're not going to comply with that, and if we get fined, we'll just pay the $300 a day. So I do feel like there is a push towards this. There's a lot of there's a lot of public support of publishing these prices. And also next year coming up, payers are going to have to publish their negotiated rates through a payer publishing stream. That's part of a different set of regulations coming out of Congress. So I think everything is moving towards publishing these negotiated rates. And so I think it's something that's not just going to go away over time. For me, I think this price transparency regulation is an opportunity. So it's an opportunity to engage patients. This is, again, at the early part of the slide, I was talking about how patients actually want this, right? They are responsible for their spending. They want to know how much things are going to cost prior. They're used to shopping prices everywhere else. So this is an opportunity to sort of lean into it and say, how can I use this ruling to make it a gain instead of a negative by reaching out to patients? And one of those is actually to, instead of just producing that file that can be downloaded, but is to actually build a website or build an interactive tool where patients can come in a friendly place and select what it is they need to shop the price for and then generate an estimate. One of the biggest problems with estimates is a lot of the feedback on the price transparency rule is that it is extremely difficult to estimate how much a particular healthcare service is going to cost for a particular patient, for the particular insurance that they have, and what their cost sharings are for that insurance, which is, that's a true statement. It is difficult because you're basically trying to simulate the charge capture, coding, billing, and claim adjudication process, trying to run that entire flow up front prior to service, and then come up with a dollar amount and put that in front of patients. The problem with estimates that are inaccurate is it actually can be a negative. So if you give a patient an estimate of what their costs are going to be and it turns out to be grossly wrong, it works against patient trust and is a negative impact on patient engagement. There's a lot of reasons why estimates are inaccurate. Again, we're trying to simulate charge capture and billing, so actually picking the right procedure codes or billing codes can be difficult, especially when there's so many ins and outs on being able to capture exactly what the charges are. Modeling the charge master, modeling payer contracts can be extremely difficult. This could get easier. This number 2 one could get easier when payers begin to publish their negotiated rates. And then the last one is you still are at the mercy of the payers to understand what their benefit levels are, what their cost sharing amounts are for their particular plan, and also up-to-date accumulators, where they are on their deductibles and out-of-pocket max, which has a big part of understanding what the patient's responsibility is. One way to address this when we're taking estimates of what their financial responsibility is and trying to use that as a positive in patient engagement is to understand that not all estimates are the same. Generating a patient coming in for a service that's generally covered as a copay is going to be accurate. So as long as their coverage is verified and you know it's a $20 or $50 copay, that's highly accurate. Things around labs and imaging, or anything where the payer pays on a fee for service and the charge master entry is pretty cut and dry, can be pretty accurate. Things that become inaccurate or become harder to estimate, surgeries, anything that involves ancillary care, situations where the payer reimbursement model is more complex than fee for service, then it becomes more difficult. And so one thing that providers can do is, instead of treating all estimates the same, is actually break it down based off of the estimate accuracy, taking into account what the billing codes are, the location, the provider, the specific plan, HMOs versus PPOs, and build a collection strategy and really an interface strategy with the patients that's specific to it. And so if you feel really confident about the estimate, then you can talk to the patient a lot more confidently and say it's going to be $120 and this is what it's going to be. Maybe even going as far as a price guarantee. And on the other end of the spectrum is if you know that the accuracy is probably suspect, is use different type of language where you're really focusing on this is an estimate only. A lot of things can change. If you're doing any type of pre-service collections on it, is just collect a percentage of it up front so that you don't have to get into a credit balance refund situation, or just try to get a card on file and an agreement to a payment plan because that ahead of time about on the accuracy. And so really the big takeaway here is that not all estimates are the same, not all patients are the same, and so by customizing the actual service that's being done, the plan they're in, and the patient's situation, you can actually build a much more effective patient engagement experience. The patient themselves, they are different, person to person. And so it is possible, again, not to have just the same policy that applies to every person. One thing really worth noticing is that the estimate has a different goal between the patient and the provider. The patient wants an estimate. They're really focusing on either price comparison if they haven't scheduled the service yet, or they're focusing on the fact that they need to budget the service, so they need a dollar amount that that needs to be put in front of them that they can say, okay, I can probably pay this over a certain amount of months, and they're looking for the options. Providers behind the scenes are putting estimates out, creating estimates and getting them out for patients, not just for patient satisfaction and to help give the patients what they want, but it's also very focused on estimates really can help drive, it's a vehicle to collect money up front, which then has a direct impact on bad debt and days in AR. So whereas providers traditionally have used the estimate and pushed them out in front of patients and said, hey, here's what your estimate's going to be and I need you to pay it. Consumers are coming from a different angle, that they're expecting this level of accuracy because they're budgeting around it. So one thing we could do is, it is possible to build custom pre-service collection actions based off of a variety of these tools that are in your toolbox. So you can start, really just the basic thing about getting an estimate, just independent of anything else, and I think this is helpful for patients, is just to show them the balance so that they're not surprised by it when they get the statement 30 days later. So if you don't do anything else, just generating an estimate to say it's probably going to cost you $450 so that they can prepare for it is going to be helpful. This allows them to then budget it, so they can look at it and say, okay, I can budget this. And it also helps with appointment cancellations, because by giving them the opportunity to understand how much it's going to cost, there may be situations where, based off the amount and based on the options to pay are in front of them, it may be better for them and for you to have them reschedule it or cancel it rather than to provide the service and then it go right into bad debt. Beyond that, there's actually more things we can do. You can get a card on file, I think, is the next step up, which is an agreement to say, hey, let's get a card on file and an agreement that says when this statement comes in, you'll pay it. And with that card on file, it opens up things like text to pay, where you can send a text message and say, hey, you put that card on file pre-service, and just answer yes here to pay as you had agreed upon at pre-service. Step up beyond that is actually setting up a payment plan. So getting a card on file and saying you're agreeing to do $100 a month until its balance is paid off. And that way you don't even have to, the only thing you have to do is say, hey, you agree to this payment plan, click yes to get it going. Next step up would be to actually take a partial payment or a payment in full. And again, this can be driven really by your estimate score. So if you look at the estimate and you know that it's you're pretty confident in it, is try to get that payment in full. And if you have less confidence, at least get a partial payment or a deposit. And then there's other options beyond that. Financial aid options, or there are other places where financial aid is available. And then, of course, third-party financing and bringing them in. The main takeaway here is to at least generate an estimate of what the patient's financial responsibility. That at least starts the process and provides, it reduces sticker shock and gives them an idea of what they're planning on, what they have to pay. And then there's all these options then you can build on once you have that estimate in their hand. It's also a requirement, again, going all the way back to surprise billing, that you may have situations where you have out-of-network patients where it meets this surprise billing requirement, where you actually have to give them this estimate ahead of time and have them sign off on it, a good faith estimate. And so having that estimate in place is also helpful there for patient satisfaction. And then again, earlier in the slide in this presentation is that patients are expecting this anyway. So more and more patients are saying, I'd like to get an estimate of how much this is going to cost. So by leaning into it and providing price transparency, allowing them to shop it on their own, which is a federal regulation, providing it after the scheduled visit, it checks a lot of boxes, and then you can use it to your advantage by building a custom flow where you try to maximize the amount you take up front to reduce days in AR and get your cash flow accelerated. The estimate is part of a bigger patient engagement, patient outreach piece on pre-service, which is once an appointment's scheduled, there's a whole host of ways to engage the patient. So the main thing I've focused on here is really around the price transparency requirement, estimating the patient's financial responsibility, and using that to accelerate cash flow and get collections up. But it's actually a player in this grander scheme where, especially on your scheduled appointments, is to be able to communicate with patients ahead of time through an omni-channel communication method. So through, again, patients want to be communicated with the way they want to interact with you, the way that they're comfortable, that works best for them. So whether it's emails or text messages or IVR, phone calls, is to be able to reach out to them multiple days prior to service and get them to confirm their appointment. And again, that estimate, get that in front of them, run them through that custom process on making payments and filling out any forms that they have, and get that process started from a patient engagement standpoint 3-5 days prior to service. Again, what we're looking at here through portals and conversational messaging is patient self-service. So just pushing this out to them and letting them see all that. And again, the estimate is a big piece of that. And then as they actually show up, hand off a lot of those processes over to point of service. So if they chose to not do it in a pre-read setting prior to service, then they can do it at point of service. If they decide to start it pre-service and don't finish it, then they can pick it back up once they get to point of service. So they may view the estimate 3 days prior, but then not make the payment till they show up, but at least they're aware of the estimate. or they may take care of everything before they even show up. And so by the time they come in, it's just a matter of intake. So this is just a small piece. The estimate is just a small piece of a broader strategy of engaging patients. But when you look at it from this angle, to have a lot of these other pieces but not tell them how much it's going to cost and start talking about collection, it's missing a big piece of the flow. So again, I like to think that these these regulations, they're often looked at it as a pain in the neck. But again, there is a model of just kind of switching this over to tragic to magic and really focusing on using these as opportunities to swing the door around the other way. One thing, just recapping some of the stuff I talked about, was you just have to produce that PDF with the shoppable services to be compliant, but it's only a small step further to actually make an interactive website that the patient can come to and allow them to select their services and get an estimate interactively on the internet. It opens up so many other avenues because you've engaged them, and then they can roll right into scheduling or save that estimate and call back, as opposed to them just downloading a giant catalog of all your prices. The other thing is being able to allow your patients, basically have your staff know what your patients are doing as well. So tooling is a big piece of that. Generating of these estimates and getting them all out to patients. A lot of that is also those same tools that your staff is seeing, so that they're following along with the patients and helping them along. And it really helps the patients and the staff to interact well. Big part of patient engagement. The estimate process itself sounds very complicated, and as I mentioned, there's a lot of reasons why hospitals have steered away from them due to accuracy issues, but I think you can take the accuracy issues around estimates and spin it to your advantage and say this is an engagement opportunity, and I'm going to embrace the fact that estimates sometimes aren't accurate, as opposed to ignoring it or just walking away from estimates altogether. Every patient's different. So the thing I talked about is, as you go through those estimate actions and everything else, is really focused on what is the service, what's the dollar amount, what's the patient's propensity to pay, the patient's situation, and how can I actually build a solution that's specific to them, as opposed to a one-size-fits-all scenario. And then the last one is basically, as I mentioned on that estimate actions, is a lot of offering payment plans, financing, financial aid, making a deposit, or basically putting down just a partial payment up front, and giving the patient a lot of different options so that they can look at it and say, hey, I can do that. So this transparency up front is to push it out in front of them and say, I'm going to go ahead and tell you this is what it's probably going to cost you. I'm going to tell you this, how confident we are based on the information we have about this service and your insurance. And here are all the different options we have for you to begin paying on it. And spin it as a positive for the patient, as opposed to a collections goal for the provider. But in the end, you'll still gain. When all is said and done, just the overall patient engagement process is, well, the final scorecard is, if this process is going well and you're engaging patients up front, you are going to see claim denials and rebills go down, bad debt goes down, days in AR goes down, cash flow improves. Just through this process, all these little pieces working together contribute to these improvements. The improvement of registration data quality is part of the overall patient intake as well. Filling out forms, registration forms, verifying eligibility, all work together to ultimately focus on, claims not getting denied or have to go through rebill, and cash flow improving. Simultaneous to that, just from the financial piece, is that the patients will be happier. The whole pre-service environment, from scheduling to point of service, is often that first contact with the patient, often for something that might be a little bit scary or confusing for them, whatever their service is. There are so many opportunities there to help them understand this is what it's going to cost you and here are your options to pay, as well as it's really easy to fill out forms and get everything you need and make your payments without it being extremely difficult. So you can actually win on both sides of the house with respect to just improving the overall patient engagement, especially around, again, the financial and pre-service collections. So I think we have time left over to look and see what questions we have.
Yes, thank you so much, Howard, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we have time for. So the first question I have for you today, Howard, is this the final ruling for surprise billing, or will there be more?
There is definitely more. So that for the surprise billing, the interim final rule was the first of probably 3, if not more. So they're basically they're taking the legislation and building a rule out of it in pieces. So there's definitely more. The stuff I covered here was the big chunk that they try to bite off the most important stuff. The one everybody's waiting on is the dispute resolution process, how payers and providers are going to resolve any disputes out of how much payers are reimbursing providers when they're out of network. So definitely more to come.
Totally. Thanks so much for explaining that for our audience. So the next question I have for you is, do you think the public is ready for price transparency?
I think, candidly, that it is that healthcare reimbursement and insurance coverage is extremely complicated, and there's a lot of ground that has to be covered to make it less confusing for patients. But I do think that the way reimbursement works now, unless it's just a cut and dry, you've been to the doctor's office, you went to your PCP and it's a $20 copay, especially some of these surgeries, I think it's very complicated. And I also think that it's difficult for providers to be able to provide pricing for things like ambulatory surgery across all these different insurances. So I definitely think that I do think that consumers need it, and they would like to know. So I would like to know if I'm having something what the price will be, but I do think we have a lot of ground to cover to make it not so confusing. So I do think that Congress's intent is noble, but it's a huge bridge to cross to actually make it practical for patients. Meaning, I don't know that patients are yet benefiting from price transparency.
Totally. Thanks for kind of that candid response and, explaining how, it's noble in nature, but, maybe we're not quite there yet. Awesome. So the next question I have for you today is, do I have to publish my physician prices for price transparency?
The only ruling on non-hospitals on physicians is if the physicians are employees of the hospital, employed by the hospital. So there has been a lot of discussion and slicing and dicing of the ruling. But if the physicians are employees, then you have to publish their prices. Now, there's also other wording in the ruling that says for these, quote, shoppable services, you're supposed to try to get a dollar amount to the patient that is going to be their total cost for this service. So again, if it's an ambulatory surgery situation and there are ancillary care involved, physicians, and those physicians are not employees but contracted in, they bill separately, you're supposed to, in the shoppable services, at least make a notice of that. Like, hey, there will be anesthesiology charges as well, so that the patient is not getting, so the patient is getting the full cost, or at least an idea of what the full cost will be. But as far as hospitals having to publish it, no, if they're not employees.
Got it. Thank you for clarifying. The next question is, one audience member would like to know if you can explain why patients may want the same experience for pre-appointment tasks as well as for billing.
Why they would want the same experience for pre as opposed, in addition to post or billing? Did I understand that right?
Correct. Yes.
Well, I think the main thing is this continuity. So, for example, if I get a pre-service estimate for $1,000, I make a $500 payment pre-service, and I do it and put my card on file to do that. Then when I actually get the statement post-service, and the statement should reflect the fact that it was, let's say, it turned out to be $1,000, it should reflect the $500 deposit that I made, or prepayment. And then when I go to the portal, the card that I put on file pre-service should be there post-service, right? So I shouldn't have to enter all that stuff again if I already set up a card. And so that the experience is the same. As I look at the statement, I should be able to see the estimate. Like, here was the estimate, here's the statement. So it's that type of experience that's the same. And it actually, since it's circular, is that if I set up a card on file or set up a experience post-service on a statement, and then I go back in for follow-up care or just another appointment, at the pre-service situation, everything I've done post-service for my previous visit should all be there. So it should be sort of a seamless experience just across the board on the revenue cycle side.
Absolutely. Thank you so much, Howard. So the next question I have is just, an audience member wrote in, one of the worries that providers have, about kind of posting some of those physician prices is that this will lead to comparison shopping. The audience member asks, in what way can they, address the concern of losing their patients?
Yeah, so I think one thing is definitely a side effect of this is, yes, you have to publish your negotiated rates, and that's actually the intent of the federal government, is comparison shopping for patients to begin to compare prices across all the different providers in their area, in their market. And it's only going to get worse when payers publish on their side. So part of this way to approach this, to me, is to actually lean into it and improve the overall patient engagement experience for patients. And so I think there's a lot of places where, a lot of examples, especially outside of healthcare, where companies have competed not just on price, but on service and satisfaction, quality of care. So I think those are the areas that providers are going to have to focus on, not just on straight price, which is to say to be able to demonstrate to patients why, if you are a little bit more than the provider down the street, that you're worth it. And that's through self-service, patient self-scheduling, accurate estimates, flexible payment options, clear and easy to understand statements and estimates. And I'm just talking on the revenue cycle side, not even addressing, the clinical care side, but just also better quality of care. I think providers are going to have to dive in to patient engagement and patient satisfaction because it's going to become more competitive.
Absolutely. Those are really good points. Thank you, Howard. So we have time for a couple more questions, so I'll try to sneak in as many as we can. The next one I have for you is, what payment options do you recommend for an estimate?
On payment options, I'm going to assume, well, I'll try to answer payment options in two different ways. One is, I think you should definitely tailor it specific to the situation. So I think in the toolbox should be options where you want to collect 100% of the estimate, and then situations where you need to collect just a percentage of it. I think it should be based off of the patient's propensity to pay. So being able to use that information to put it into quadrants to decide how much you want to collect. And I think payment plans definitely should be an option. So get them to agree to a payment plan that either starts right there at point of service, or a payment plan that starts when the statement arrives, when it actually adjudicates and the balance is determined, payment plans. But also on just payment methods, I think, again, a full suite. The easier you make it for the patient to pay, from credit card to Venmo to Apple Pay and Google Pay, the better, right? So no barriers. Everybody wants to pay a different way that makes them comfortable. And so having a big toolbox full of tools, full of options, is gonna maximize it. But I think it's not one size fits all, right? So I think it is possible in today's world, with the technology and tools out there, the vendors out there, to build solutions that match the patient.
Awesome.
And that's it.
Thank you so much. Yeah, for sure. Thank you so much, Howard. So one more question for you. Does the No Surprises Act require a new consent form? The audience member said that she heard in the webinar there was a common template being set up, and would just like to know a little bit more about that.
Yes, there is. So if there is a lot of specifics on when you can actually, when it kicks in, where you actually have to get that consent form signed. But yes, there's a new consent form that if you are an in-network facility and going to bill out-of-network charges, because you have physicians that are out of network, there is a consent form that has to be given to the patient. That 72 hours prior, HHS has released a model form of it. It's in the deck. It's in this deck, a couple slides back. It's a 4-page model form. Includes a good faith estimate, and that you have to actually put in there the actual services and what it's going to cost them, and then they have to sign it and agree to pay out of network rates. So that is a new form, and it has to be given to the patient, again, 3 days prior to service.
Awesome. Thank you so much, Howard. That will conclude the webinar. That is all the time we have left for today. Before signing off, I did want to address one more question that we had pretty commonly from the audience, which was about the PowerPoint slides and if they would be available for download. They are in the resources section on this platform, but if you cannot access them, we will be emailing in a follow-up message. You will have access to them, is essentially the answer to that question. But that is all we have time for today. I want to thank Howard for his excellent presentation and RevSpring for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.